So today we'll be talking about a very important topic, that is atypical HUS, and sometime uh, is one of in the previous video we have discussed typical HUS. So atypical HUS is also known as genetic HUS or non-diarrheal HUS, complement mediated HUS. So it's an umbrella term. Normally the complement-mediated HUS is termed as atypical HUS. It could be caused by certain other causes. However, it's very rare as compared to typical HUS. And for genetic HUS, it's called genetic HUS because sometimes it follows a Mendelian inheritance in autosomal recessive or autosomal dominant condition. Uh, and the penetration for it's low because sometimes the sibling may be carrying same gene but with different manifestation. Uh, so what the at the core, either there is some certain regulatory factor deficiencies, or in some cases there are antibody against certain complement pathways. Okay, so these are some of the factor H, I, B, NC3 deficiency, and similarly cobalamin or Van-Welle-Bryan cleaving protease deficiency. So what happens actually, there is, due to deficiency, there is a failure of complement regulation, and there is an uncontrolled activation of the alternate pathway, which leads to membranotic complex formation and endothelial damage. In atypical HUS, they're like potentially they have the activation, the unregulated activation of complement activation, but it does not happen as such unless there is a trigger event is present, like an infection, non-specific viral illness, pregnancy, or some drugs. So when the trigger factor is present, alternate pathway is activated in uncontrolled, unregulated manner, and it leads to the formation of membrane-attack complex, and finally renal endothelial damage ensues, which causes thrombotic microangiopathy, leading to anemia, thrombocytopenia, and renal dysfunction. Now, the management includes, normally we do investigation. We can do genetic testing and assays of different factors, and these are the investigations. And for management, we start with the plasminoxane, that is followed by immunosuppressive therapy with corticosteroid, rituximab, and cyclophosphamide. But however, the mainstay remain the monoclonal antibody eculizumab, which blocks the CP activation, C5 activation. So when C5 activation is blocked, no more membrane attack complex. It don't regulate the membrane attack complex formation, and what happens that further endothelial damage is stopped. It's very effective, and also in the renal transplant patient where atypical HUS occurs. Okay, I will be discussing another HUS which also is somehow related to atypical HUS, is that in pneumococcal associated hemolytic uremic syndrome. It occurs most commonly in infants and young children, and three mechanisms have been actually supposed to be like at the core of causing HUS, and one is the plasminogen activation, where more plasmin is produced, and that lead to FDPs and complement activation, resulting in endothelial damage. Similarly, complement mediated, and the third one is neuroaminidase, which is thought to be that it cleaves and it exposes the T antigen on RBCs, endothelium, and glomeruli and platelets, and endogenous IgM binds to it and thus cause the endothelial damage. Clinical presentation for pneumococcal is 70% of the time it will present with pneumonia and empyema and parapneumonic effusion. The second common presentation is meningitis, sinusitis, and otitis media could also occur. Management is usually supportive management, like the fluid, dialysis, transfusions, nutrition, An antibiotic vancomycin could be used, and it is somehow different. This indication for antibiotic is somehow different than the actual. In the typical HUS, we want to avoid antibiotics, but here it is indicated. It is actually at the mainstay. Similarly, transfusion plasma exchange is considered to be contraindicated by some authorities because they say that the plasma contains endogenous IgM, and that could bind to the T receptors on the RBCs and platelets and glomeruli, and that could exacerbate the course of the disease. Thank you.